Wuhan? When
In 2019.
2019. Okay, okay.
Yeah. I have such fond memories of that time. You know, it was,
we have a good photo, right? Okay.
Yeah, for sure.
I was surprised you are familiar with kanji, Chinese characters.
Yeah.
Very impressive.
It is interesting to me that someone like you don't speak Chinese. I mean, you don't speak Mandarin, but you understand the kanji, so you can actually read it, right?
I can read it perfectly.
Yeah, that's interesting, right?
Fine.
The idea that you can read and understand, but you don't understand the spoken so well, right?
Yeah.
So do you still have snow now?
Little bit. Almost gone.
Okay, good.
So do you want me to stop sharing the slide once?
No, it's perfect. Just leave. No, just leave it like that.
Can I leave it?
Yeah. Just leave it. And then, Didi, do we have to help Chris Ogilvy with the link?
I sent it to him, so I'm hoping I'm texting him now. I'm hoping he has it.
Yeah, let's text him and see if he can. Very good. Do you have more Chinese fellows now, Miki?
Yes. In my laboratory, 4 Chinese.
Really?
Postgraduate student.
Oh, very nice. And clinically, if someone wants to learn,
not just for the basic research.
Oh, really? But if we had a resident or a fellow who would like to spend some time with you, is that possible, do you think?
I think it's possible.
Okay. Good.
In Sapporo, there are many high volume centers here, so
really?
They can visit multiple places. Yeah.
Very nice. Very nice. How many Moya-moya cases do you think? How many Moya-moya surgeries are being done in Japan in a year?
In a year, entire Japan? I have no idea. Maybe 800,000, nearly 800 or something.
Oh, wow.
Yeah. But in China, they have more, much higher.
Is it the same kind of genetic?
No, different. South Korea, Japan are almost the same, but China, a little bit different.
It's different?
Different. You mean the susceptibility gene from
Yeah.
Little bit
it's a different one.
Different genetic backgrounds between China.
But the disease is manifesting the same, or the Chinese?
I think almost the same.
It's almost the same. Okay. Same progression.
Similar progression, but
interesting.
So it's early in the morning, right? 7:30.
Yeah, it's the start of the day.
Okay.
But we have time. Very nice. How's your piano playing?
Piano. Personally, I play violin.
Violin. Sorry. How's the violin? How's your violin?
Yeah, I have a good friend here in Sapporo.
Okay.
And we make we enjoy music. So
he plays the violin too, or plays the
piano. Some of the professor in pediatrics play piano, nice. And another one plays cello. So
nice. Yeah. So you do trios?
Trios. Last time the Beethoven's.
Nice.
Nice. Trio. So
that's very nice.
How is your new life in East Coast?
It's good. It's a big transition. It's very different atmosphere and surroundings, and But it's a very interesting place. We get very interesting cases. You were in Utah. You saw Utah is like cowboy country.
But I loved it.
You liked it?
Yeah, I liked it.
Yeah. Yeah.
I was wondering to visit Yellowstone via
Oh,
your
yeah.
place, but you moved to East.
Yeah.
Yeah.
Next time.
Yeah.
Here in Harvard, still all the grand rounds are online. But I hope that's going to change next year, and then maybe we can have you as a visiting person visiting professor in person here, because I think it's nice for you also. Because I really enjoyed it when you sat down with the residents in Utah.
Okay.
You know, we could discuss cases and manage.
Yeah,
It's really important. So we have slowly people joining us. Let me make sure that Dr. Ogilvy is okay to join us. Oh, perfect. Chris,
Hi. Let's see.
let
if
me
I'm-
introduce you to Professor Fujimura. Chris
Hey,
Ogilvy.
Oh, good
how
morning.
are you? I'm sorry, I had trouble logging on. I apologize.
Okay. Professor Ojirvi, thank you for your kind invitation to this grand round. It's my great
Well-
honor to be here. Thank
Well,
you.
thank you for doing it. I know we're far away in distance, but I've been to Sapporo and I've been to Japan a number of times, and I very much enjoy it and really appreciate you making the effort to do this. Obviously, your experience in this particular area is vast, so we're really excited to have you talk about this. And
Thank
we
you.
have an adult Moya-moya center, so we're seeing a lot of adult Moya-moya disease here at our hospital. There we go. What time is it there for you?
In Japan, it's 8:30 p.m.
That's what I figured. It's about 11 or 12 hours different.
Okay.
But thanks again for doing this.
Of course, my pleasure.
And Dr. Telsky will introduce you.
Thank you.
I think we still have time, Chris, a little bit until everyone logs on.
Miki, how big is your hospital?
Big, just 800 beds.
Uh-huh.
And neurosurgery, 35 to 40 beds.
Good. Yeah, that's excellent.
But we have a group, department group hospital, so we have a multiple hospital.
Right. Feeding hospitals.
Yeah, it's something like that.
Oh, no. Let's see. Huh. Strange.
Here, can I continue sharing my slides like this?
Yeah, you're good. You're
Okay.
good. Yeah.
Yes, it looks excellent.
We'll give it, Miki, we'll give it until 7:30 our time here, and then I'll introduce you.
Okay. When I start my lecture, I will make it in the slideshow mode.
Okay, perfect. Let's give it another minute or so.
Okay.
So good morning, everyone. It's a great and distinct pleasure and honor to welcome with us for neurosurgical grand rounds a good friend, Miki Hujimura. Let me give you a little bit of his background. He has an outstanding background as a surgeon, as a researcher, and also as a teacher of fellow surgeons. He was previously the chair and director and chair at Konan Hospital in Sendai, Japan. Konan Hospital is very important to us because it's the origin of Professor Sutsuki's angiographic description of Moya-moya, and it's really the birthplace of Moya-moya disease and management and study. He's been now for 2 years the professor and chair in Sapporo at Hokkaido University. It's one of the how did you call it? Empire universities.
Yes, 7.
So it's a great honor for him to move to Sapporo, where he's now for 2 years. It's a very big department. There are over 40 neurosurgeons. He dedicated his entire surgical and research career really to the study of cerebrovascular disease, but mostly to Moya-moya disease. And he's a real triple threat in the sense that he's not only interested in pure surgical nuances in the management of Moya-moya disease, but he also has a basic science research lab where he studies the genetic basis and vascular etiology and pathology of Moya-moya disease. Additionally, and I think that's very important, he has a great track record as a teacher of fellow surgeons. I saw myself, a young neurosurgeon from Wuhan University, Jianzhen Zhang, spent half a year with you, Miki?
Yes, half year.
And is now one of the top Moya-moya surgeons in China. And not only is he one of the top Moya-moya surgeons, he's also a great researcher, publishing. Recently, they published together a paper in Journal of Neurosurgery on flow regulating site-to-site STA-MCA bypasses for Moya-moya disease. So I think really great. And we're really excited to hear from Professor Hujimura now about the latest in the surgical management of Moya-moya disease. He's also very heavily involved with the Japanese Neurosurgical Society. He's on the board of directors there, and he's responsible for all the guidelines in Moya-moya disease, in management, diagnosis, and so on. So a real giant in the field. So thank you very much for joining us today.
So thank you very much, Phil, for the kind introduction. It's my great honor to be here, and I would like to thank Professor Ogilvy and Professor Totsuki for giving me this opportunity. So I would start my lecture now. So today the topic is Moya-moya disease. So again, I'm from Hokkaido now, but originally I'm working in Sendai City, where is the birthplace of Moya-moya. And now I moved to Hokkaido, the another northern island here. And the Sapporo is the capital of the Hokkaido area. So about 2 million populations here. And I'm now working here for 2 years. So today, it's my pleasure to talk about Moya-moya disease, because Moya-moya disease is very important disease for the cerebrovascular surgeon, because recently the bypass surgery for Moya-moya, it sounds like one of the best indication of the bypass surgery. So also in Japan, increasing number of Moya-moya disease patients undergo bypass surgery. So because of the guideline recommendation clearly show that there is a definitive indication for the symptomatic Moya-moya disease. Today I would summarize these standard management and also about the perioperative issues. So starting with the history of Moya-moya disease. So there was no CT scan and no MRI at this meantime. 1957 or 1960s, the Japanese colleagues found very particular diseases, like which is defined as a idiopathic terminal ICS stenosis with the abnormal vascular network formation with bilateral involvement. This could be the original definition of Moya-moya disease. And Professor Jiro Suzuki, in the first professor of Tohoku University in Sendai, named this disease as Moya-moya. Moya-moya means something like cigarette smoke. We express the Moya-moya cigarette smoke or something like that. So this is the origin of the Moya-moya disease. So now we know that the Moya-moya disease is the idiopathic cerebrovascular disease with unknown etiology, characterized by these angiographic figures. But that description only represents one stage of Moya-moya disease. Please, this is one of the most important slides for the definition of Moya-moya disease. This is a Suzuki's angiographic staging. Of course, it does not reflect the severity of Moya-moya disease, but this staging represents a temporal profile, how Moya-moya disease progress and compensate their ischemic condition by themselves. Moya-moya disease starts with the narrowing of the carotid fork, and then there was a development of the Moya-moya vessels to compensate the ischemic condition intracranially. But after that, there is a lot of transdural collaterals developing from the external carotid system. Then the intracranial Moya-moya vessel decreased, and ultimately all the brain cortex were supplied by the external carotid system. Some patients go to the stage 6 even without surgery. So this is something like an internal carotid, external carotid conversion. So I would answer, what is Moya-moya disease? Yes, Moya-moya disease is ICEC conversion disease with a transitional Moya-moya phenomenon. ICEC, recently some people say intracranial, extracranial conversion, but internal carotid, external carotid, either way. Anyway, ICEC conversion is a physiological reorganization system to represent the temporal profile of Moya-moya disease. It's very important to understand this pathology, the macroscopic pathologies. So in fact, look at this patient. This is a 60 years female, and she only suffered a minor stroke in her life. And on the right hemisphere, there is a typical Moya-moya disease, terminal ICS stenosis with abnormal vascular network formation. But look at the left hemisphere. There is no ICA, and the entire cortex were exclusively supplied by the external carotid system. Again, this patient did not undergo any surgery. So there is a spontaneous progression to the stage 6. So this can happen in the patient with Moya-moya disease. But most of the patients suffered ischemia or the hemorrhage from the abnormal vascular network at stage 3 or 4 and come to the hospital. So it's relatively rare to find the stage 6 in the clinical setting. This is the left hemisphere of this patient. Medium meningeals or many occipital arteries or STA, or there are so many pyrosynangiosis from the external carotid system. The question is, why can Moya-moya disease patient can develop this kind of pyrosynangiosis from the external carotid system? Because it does not happen in a patient with atherosclerotic patient. One of the reasons which facilitates the development of the this kind of pyrosynangiosis could be that recently, this is a next slide, which shows the intrinsic vascular pathology of Moya-moya disease. Recently, we have a MRI vessel wall imaging, which clearly showed the completely different vascular pathology. This is the atherosclerosis, which has the extrinsic thickening of the vessel wall. But look at Moya-moya disease. The outer diameter is very small and the vessel wall is very thin, like this. So this is a very opposite pathology compared to the atherosclerosis. So this is a so-called negative remodeling. Recently, the keyword is a positive remodeling, atherosclerosis, and negative remodeling in Moya-moya disease. So I speculate that this kind of a very thin and fragile vascular structure may facilitate the possibility of the development, plasticity of the pyrosynangiosis development. This is a very classic histological characteristic of Moya-moya disease, which is compatible with the vessel wall imaging in the previous slide. And the most important characteristic is the medial wall, medial layer thinness, and also the internal elastic lamina is significantly compromised, tortuousness of the internal elastic lamina, which again represent a very fragile vessel wall structure of Moya-moya disease. It's not only at the wheel slings, but also the M4 segment of the brain surface vessels also have this characteristic. This is a very challenging fact for the neurosurgeon because we make anastomosis to the M4 segment of the middle cerebral artery, but this vessel itself has a very thin medial layer and small outer diameter. So the bypass surgery for the Moya-moya disease is very technically challenging because of the intrinsic fragility of the vessel wall at the recipient artery. So we should mention that we manipulate the very fragile pathological vessels during the procedure of the anastomosis. So today I'm talking about the very standard surgical indication and microsurgical procedure for Moya-moya disease. But for the introduction, I was talking about the basic pathology of Moya-moya disease. Macro pathology as a Suzuki's angiographic staging, and the microscopic pathology as a negative remodeling, small outer diameter of the vessels, and the very fragile vessel wall structure. So the second part, I will talk about the perioperative management. The intrinsic cerebral hemodynamics in the acute stage, the hyperperfusion syndrome or very characteristic ischemic pattern. I'm going to show these things later on. So let's go to the very standard aspect. This is a first very important slide about the surgical indication for ischemic onset Moya-moya disease. This is a guideline recommendation of the most recent Japan Stroke Society. For the ischemic patient, surgical revascularization is reasonable for Moya-moya disease manifesting as cerebral ischemic symptoms, such as transient ischemic attacks or minor stroke with a modified Rankin scale 0 to 2. Okay, this is a recommendation grade B. And more importantly, STMC anastomosis, direct bypass is recommended for the adult patient. But for the pediatric patient, either direct, indirect, or combined revascularizations are acceptable for pediatric patients. So importantly for adult patients, direct bypass is recommended. So again, if we go back to the macropathology of Moya-moya disease, we recognize that the extracranial, intracranial bypass, either direct or indirect, had a perfect concept for the Moya-moya disease to complement the physiological reorganization system of the ICEC conversion. Patient has a very naturally have this ICEC conversion potential, and the bypass does not intend to beat Moya-moya disease, but to support, complement this ICEC conversion system. This is one of the very unique point of the status of revascularization for Moya-moya disease. So the question is direct, indirect. Which is better, or combine is better than the direct only, or there are a lot of questions because we have a lot of surgical procedure for Moya-moya disease. But recently, again, for the symptomatic adult patient, this is a meta-analysis from the South Korean group, and it also showed that the direct bypass showed better future stroke prevention than indirect bypass in adult patients. And also the direct bypass was associated with better angiographic outcome than the indirect bypass. This is a very famous meta-analysis. And unfortunately, we don't have a randomized control trial for the ischemic onset Moya-moya disease, only the case series or something. But this meta-analysis clearly showed that the superiority of the direct bypass for the adult Moya-moya disease patient. So I would simply show the very straightforward representative case of 30-year-old woman who has a transient ischemic attack, weakness of the left hand, which means ischemic symptom on the right hemisphere. And single photon emission CT shows the bilateral hemodynamic compromise, especially on the right hemisphere. So personally, I only operate on the symptomatic hemisphere. So I recommended the patient to undergo the right STMC anastomosis combined with indirect pyrosin angiosis. This illustration shows the skin incision along with the parietal branch of the STA and craniotomy. And it's a very short movie, 3 minutes movie. In the center of the field, I found a favorable recipient artery. But again, this vessel has a negative remodeling. The medial layer is very thin, and the internal elastic lamina is significantly compromised. So we need to make it in a very gentle way. So I use aspirin before and after surgery, and complete heparinization on local heparinization during the procedure, and 20 minutes anastomosis here. I see green clearly shows the patency of the bypass and the relatively good distribution of the I see green at the surrounding cortex. So there is no parenchymal changes. So this is a procedure of the indirect bypass. Before the cranioplasty, I split the temporal muscle to 2 layers, and I inserted the inner layer on the brain surface. And here is the entry of the STA. And I also use the collagen matrix as a scaffold for the pyrosynergiosis, not only outside, but also inside. So then, and the cranioplasty. So this is a very simple combined revascularization procedure. For the cosmetic reason, I use a bioabsorbable plated cosmetic area. So this is a very standard procedure of the single STMC anastomosis combined with the indirect pyrosynergiosis. So the STMCA bypass can be clearly visualized by the postoperative MRA, and single photon emission CT shows the significant improvement of the cerebral blood flow 1 day after surgery. This is a very ordinary temporal profile of the patient with Moya-moya, and she didn't suffer any ischemic attack after surgery. So this is a standard bypass for the anterior circulation. We can use the same concept also for the second surgery for the posterior circulation. So if we look next, I would introduce the OA efficacy of OA PCA bypass for the repeated ischemic symptoms. This patient is a child onset Moya-moya disease who has a history. Okay, who had the history of the anterior circulation STMCA bypass bilaterally. But 3 years later, there was a gradual progression of the PCA stenosis like this. And ultimately, the right PCA disappeared. And at the meantime, the patient suffered a transient ischemic attack on the right hemisphere. So we, again, flow study is very important. And when I performed the single photon emission CT, there was a decrease of cerebral blood flow at this area. And the patient suffered the repeated numbness of the left hand, and also the visual field disturbance. So we decided to make additional surgery of STM's OA PCA bypass combined with. Someone should have a mute, please. Okay, so this is the OA PCA bypass. So I also make a cut down procedure. I make a skin incision along the occipital artery and make a small L-shaped incision and make a craniotomy. And the spinal drainage is very important because when we make a posterior craniotomy, sometimes the brain swollen. So I will skip because of the time. I will make it very shortly. So okay, this is the occipital artery. We can make a manipulation in the same way like STA, and there is a 2 branch of OA, and so I preserve 2 branch, and I would see the brain surface. If there is a good candidate, I would make a OA PCA bypass. If there is no, I would finalize with the EDAS. But fortunately, we have a good recipient of PCA branches. So again, the vessel wall structure is very fragile and very, very thin and very fragile. And we need a counter pressure like this. You saw my left hand. Anytime it's very important to make a counter pressure on the left hand, not to damage the recipient artery. This is also the 20 to 25 minutes anastomosis. Look at this very thin, but okay, very thin recipient artery vessel wall. I think anastomosis speed is not very critical, but the complete heparinization local heparinization is very important, and also the use of the antiplatelet. So this is one branch of the OA for the EDAS, and there is another branch of the direct bypass. This is the OA PCA anastomosis with OA PCA bypass with EDAS. So look at this craniotomy. It does not affect the primary surgical field. So this patient has this kind of patent OA PCA bypass, and there is no ischemic complication. So there is apparent cerebral blood flow improvement like this. So I think the direct indirect combined bypass is very effective also as a second look surgery like this. So this is the park in Sapporo city. So I welcome everyone to visit my city. So the first part is the ischemic Moya-moya disease, but this next part is the surgical indication for hemorrhagic Moya-moya disease. 10 years ago, there was no answer whether to operate on the hemorrhagic Moya-moya disease, but now we know that the revascularization surgery is reasonable for hemorrhagic Moya-moya disease, especially posterior hemorrhage. Posterior hemorrhage is very important, I think. So posterior hemorrhage. So why posterior hemorrhage? This recommendation is based on the result of the Japan adult Moya-moya trial, which is a randomized controlled clinical trial to clarify the efficacy of the direct STMC anastomosis to prevent rebleeding in patients with adult hemorrhagic Moya-moya disease. We made a stratified randomization, and the results showed that if the primary hemorrhage, hematoma, is located at the posterior circulation territory, like a thalamic hemorrhage or something, this kind of posterior hemorrhage patient has a significantly, remarkably high risk of the rebleeding. The rebleeding risk is as high as 17% per year if the patient observed. But if the patient undergo STMC anastomosis, the rebleeding risk was significantly decreased like this. This is a very positive result in this subgroup. So that's why we recommend bypass surgery for the posterior hemorrhage patient. So based on this, the result of JAM trial, now in Japan, posterior hemorrhage patient undergo bypass. The first question is why posterior hemorrhage? Everyone asked by ourselves, why posterior? Because the bypass sounds like bypass is for the anterior circulation, but why posterior hemorrhage had a benefit by the bypass? The answer to answer this question, the keyword is a choroidal channel. Choroidal channel. What is choroidal channel? Choroidal channel is a Moya-moya vessels, posterior Moya-moya vessels, which is characterized by the extended dilated choroidal artery connected to the medullary artery. This kind of posterior Moya-moya vessel is a bad sign for the high rebleeding risk. So this is a choroidal channel. So now we think the choroidal detection of the choroidal channel is very important. In fact, this is a supplemental analysis of JAM trial. And if the patient has the choroidal channel on one hemisphere, that hemisphere has a future rebleeding risk of 13%. But if the hemisphere does not have choroidal channel, the bleeding risk is very small, very low. So this clearly shows the significance of choroidal channel for the rebleeding. And the choroidal channel can be easily recognized by this kind of MRA-MIP slide like this, periventricular anastomosis. We can imagine this kind of a very fragile vessel which faces to the ventricles could result in a bad hemorrhage, future hemorrhage. So it's very important to recognize whether or not the patient had the choroidal channels. So one representative case, 30-year-old woman, posterior hemorrhage. Fortunately, she recovered to the modified ranking scale 1. So I recommended surgery for her because she had a definitive Moya-moya disease with a marked development of choroidal channel like this. So I explained the high bleeding risk for this patient, and she decided to do bypass surgery. The very small negative remodeling reflect the vessel diameter as small as 0.6 millimeter, but sometimes a hemorrhagic Moya-moya disease patient has much more fragile vascular wall structure. I think sometimes more than the small children. The counter pressure is again very important to stabilize the recipient arteries. One side to other side. Okay, even though the vessel diameter is small, we can make a fine anastomosis like this. So I think the technically hemorrhagic Moya-moya disease patient has a technically very difficult condition, I think. Okay, so anyway, she has this benefit by the bypass surgery, and she doesn't have any rebleeding during the past 5 years. Gradual improvement, and at 1 week there is a good distribution like this. So this is the most recent paper by Kyoto University, and I talked about the choroidal channel at the posterior part. So one may wonder if the bypass flow go to the posterior part, maybe it's more effective to reduce the choroidal channel. So this study is a retrospective study, but they examine, this is the first pattern, and bypass flow is mainly feed to the posterior to central sulcus, posterior pattern, which sufficiently reduce the choroidal channel. But if the bypass flow mainly go to the anterior to central sulcus, there are less effective reduction of the choroidal channel. So maybe the concept of the bypass surgery is recently changing. Historically, many people say that the anterior bypass is very important to preserve the cognitive function. But from the viewpoint of the hemorrhagic stroke prevention, maybe not only the anterior, but also the posterior bypass is very important. So now we are discussing this surgical nuance for the prevention of the hemorrhagic stroke. Again, the combined surgery. So indirect bypass alone is not recommended for the adult patient because some patient does not develop the pyrosynoangiosis at all. So recently, we were looking for the good biomarker. This is, by the way, this is one of the very important genetic variant among the East Asian Moya-moya disease patient. This is a very famous genetic variant, which is the RNF213, which is located at the 17th chromosome 17th. This is a single nucleotide polymorphism, and surprisingly, 80% of the Moya-moya disease patient in Japan have this kind of particular variant in Japan. Also, it's also true in South Korea. So 80% patient have this variant. So it's a very important susceptibility gene among Japanese patients. And more interestingly, recently, this RNF213 variant was reported to be correlated to the negative remodeling. This is interesting data. This is a series of non-Moya-moya intracranial atherosclerosis, arterial stenosis, and even with non-Moya-moya patient in Japan, 30% patient had a RNF213 variant. But what is interesting was that this kind of RNF213 variant patient has much smaller outer diameter of the vessel structure, so which could call the negative remodeling. So there is a significant correlation of RNF213 and negative remodeling. So we speculated that the patient with this variant has more development of pyrosynangiosis from the indirect bypass, because the negative remodeling again could be the very favorable condition to develop the new network because of the very thin vesicle structure. So we examine the development of the pyrosynangiosis after combined revascularization surgery by chronic stage MRA in the consecutive 93 hemisphere of adult Moya-moya disease. Of course, direct bypass is effective, but in patient with the RN213 variant patient, there was a significant development of the indirect bypass, especially from the deep temporal artery. So this kind of RN213 variant patient has more chance to develop the indirect bypass after the combined revascularization. This result was also true in pediatric patient. We also confirmed that also in the pediatric patient, the patient with this particular variant had more development of the indirect bypass after combined revascularization. So in my opinion, 80% of Moya-moya disease patient in Japan has this variant. So as long as in South Korea or Japan, I think combined bypass is superior to the direct bypass only. So in fact, I personally continue the combined revascularization during the past 18 years. So this is a little bit of basic talk about the genetic background in the East Asian Moya-moya population, which may lead to the negative remodeling, outer diameter narrowing, vessel wall thinning, something like this, which may facilitate the development of the new network like pyrosynangiosis, development of the pyrosynangiosis from the external carotid system, which may ultimately explain the facilitate the intracranial extracranial conversion, which is a macroscopic basic pathology of Moya-moya disease. This is our speculation, but so superiority of combined revascularization compared to direct bypass alone is reported in the multiple papers. Combined bypass is a wider vascular territory, favorable long-term outcome, more CVF improvement of AC territory or something like this. So after this, I will move on to the perioperative management. Sapporo is a beautiful city like this. So perioperative management. So this is complication avoidance is very important for us neurosurgeon. So I spent my life on this topics, and Moya-moya disease surgery. Surgical complication include, of course, the cerebral ischemia and the cerebral hyperperfusion syndrome and others. So I would mainly talk about the cerebral hyperperfusion syndrome, which may result in the transient neurologic deficit and the delayed intracerebral hemorrhage or seizure. 20 years ago, many people say the risk of the hyperperfusion after low flow bypass is very low. 20 years ago, many people say that. But nowadays, we know that in Moya-moya disease patient, a low flow bypass can cause symptomatic cerebral hyperperfusion or hemorrhagic hyperperfusion in some patient. This kind of complication is extremely rare in the atherosclerotic patient. So this could be the characteristic complication in adult, especially in adult Moya-moya disease patient. Again, 10 to 15 years ago, many people believe hyperperfusion cannot happen in Moya-moya disease, but look at this particular patient. I may in a very primary case, primary series of my experience, and I make a single bypass on the left hemisphere, which was successful. I was very happy to see this. But from the post-operative day 2, patient suffered the blood pressure dependent worsening of aphasia. So I very carefully reduced the blood pressure. At the meantime, blood pressure lowering was contraindication for Moya-moya disease at the meantime, but I very carefully do this, and the patient symptom was improved after the reduction of blood pressure. And again, I performed the flow study, but there is a hyperperfusion at the responsible area. So I realized that the symptomatic hyperperfusion can occur in adult Moya-moya disease patient. This is a hemorrhagic onset Moya-moya disease patient. And after the endoscopic management, she improved her symptoms. So we recommend surgery for her for the hemorrhagic Moya-moya disease patient. This is a representative case of hyperperfusion. The 50-year-old woman left STMCA bypass, but look at this area. There is a hyperemia on this area, intraoperative hyperemia. No hemorrhage, but hyperemia here. And postoperatively, she represents this kind of very remarkable local high CBF area. And subsequently, she suffered the transient aphasia, simple partial seizure. And if we look at very carefully at this area, there was a vasogenic edema on this patient. This patient clearly showed that this is a very typical severe hyperperfusion. After the blood pressure lowering, she improved her symptom and she was discharged without the neurologic status worsening. So perioperative management is very important in patients with Moya-moya disease. But the next question is, the purpose of the bypass surgery is to increase the cerebral blood flow. But how much increase is favorable and how much CBF increase is pathological? This is a very important question. To answer this question, we make a very local CBF measurement and make a ROC analysis to clarify how much increase is pathological. For example, this 40-year-old patient had the more than 240% increase, local increase of cerebral blood flow compared to the preoperative status. And then she subsequently suffered hemorrhagic hyperperfusion. This is a very rare complication, less than 1%, but it can happen. So we make a ROC analysis for the consecutive cases. And in conclusion, the pathological threshold for the symptomatic hyperperfusion is 184% local increase of CBF. And if the CBF is increased more than the 240, 250, the patient has a significant risk of hemorrhagic cerebral hyperperfusion. So, but the important thing is that we should make the region of interest in a very small area. Otherwise, we lose the significance because the CBF increase is very localized in patients with Moya-moya disease 1 day after surgery. Again, these results were based on the single photon emission CT 1 day after surgery. So the most patients become symptomatic at the 2 or 3 days after surgery. So it's very useful to perform any flow study, CBF flow study, immediately or 1 day after surgery to predict the perioperative clinical course to make a favorable perioperative management. So now the prophylactic blood pressure lowering is accepted in patient with, especially in adult Moya-moya disease patient, but not excessive blood pressure lowering, just below the 130 mercury. And we also use aminocycline, anti-inflammatory antibiotics. And 1 day after surgery, we perform the SPECT scan and then control the blood pressure window based on the flow studies result. So finally, but I would emphasize this is a final part of my talk, but finally, I want to emphasize the pitfall of the diagnosis of hyperperfusion syndrome, which is, please remember the watershed shift phenomenon. Okay, sorry, this is Japanese. This is at the site of the anastomosis. This is a surrounding cortex. At the site of the anastomosis, this patient has a significant cerebral blood flow increase. The hyperperfusion phenomenon here. But if we look very carefully at the adjacent cortex here, there is a paradoxical CBF decrease on this area. This is a watershed shift phenomenon. Hyperperfusion and simultaneous paradoxical CBF decrease adjacent to the local hyperperfusion. So this the incidence of this phenomenon is not very low among the almost about the 10% among the adult cases. So when the patient becomes symptomatic and when the SPECT shows their CBF increase, we should also take care of the surrounding cortex and to see whether which one is responsible for the symptoms. And again, the blood pressure, correlation of the blood pressure and the patient symptoms is very important. If the hyperperfusion is responsible, blood pressure lowering may improve the symptom. But if watershed shift ischemia could be responsible, blood pressure lowering could worsen the patient's symptoms. So I think the perioperative management of Moya-moya disease has a lot of pitfalls, but please remember the watershed shift phenomenon, especially in the adult case. This is a scheme of the schema of the watershed shift phenomenon. If there is a very weak anterograde blood flow preoperatively, and there is a bypass, of course, this part could be the hyperperfusion area, but there could be the transient conflict at this part, and this surrounding cortex could be temporarily become hypoperfusion due to the conflict of this area. But at 1 week, in my impression, there could be the good distribution in the later time points. So I think after the direct bypass for Moya-moya disease, 1 week perioperative period is very important for the patient, I think. So not only the hyperperfusion, but also this kind of paradoxical ischemia by watershed shift phenomenon should be mentioned at the basic pathology of the perioperative period. Sorry, again, this is very important, so I repeat it. And to prevent the hyperperfusion, blood pressure lowering is very effective. But excessive blood pressure lowering could cause the ischemic complication, not only at the remote area, but also at the same operated cortex if the patient has a watershed shift phenomenon. So now, and also we also make aminocycline, which is a potential role for preventing the matrix metalloproteinase 9. So which could be the new protective for the blood-brain barrier maintenance. So we make aminocycline to reduce the risk of hyperperfusion. Fortunately, minocycline also has a neuroprotective effect. So I like this agent and I use it in all cases of Moya-moya disease patient. So I would conclude that the basic pathology of Moya-moya disease include dynamic nature to convert their vascular supply from internal carotid system to the external carotid system, so-called ICEC conversion. And another characteristic is a vessel wall fragility, mid-layer thinness and negative remodeling vessels. And combined, direct, indirect, combined revascularization is recommended for ischemic Moya-moya disease and also the Moya-moya disease with posterior hemorrhage. And the surgical complications such as the local hyperperfusion and cerebral ischemia should be avoided by intensive perioperative care. Thank you so much for this opportunity. And my data, today's data is mainly from either from the Tohoku University Sendai and also at the Hokkaido University. Thank you very much. Thank you for your attention.
Thank you very much, Professor Fujimura. That was a wonderful overview of really the latest in Moya-moya management from a surgical, but also basic science perspective. I know there's a lot of questions. I already saw some on chat and I have some myself, but anyone wants to go first with a question? Otherwise, I'll do the one in the chat. So one of the questions in the chat was, do you do several blood flow measurements in all post-op patients or just when they're symptomatic?
Thank you for the great question. This is a great question. I would say that it should be routinely performed. I performed SPECT 1 and 7 days after surgery for all the patients, but especially I recommend to do that for the adult patient. Pediatric patient, it should be okay, but for the adult patient, I think very important to perform the CBF study routinely, I think.
Can you talk maybe a little bit about the advantages of SPECT versus CT perfusion? Because we're so familiar now with CT perfusion for stroke, but what advantage do you see in SPECT over CT perfusion?
I think either way, CT perfusion is also effective. My Chinese colleague do the CT perfusion instead of SPECT. So any kind of CBF measurement should be okay. But maybe optimally the quantitative measurement is better.
Finally, I wanted to ask you, so one of the indications for Moya-moya disease surgery is really symptomatic status. But sometimes you have patients who show severe progression. You do a CT perfusion and they have severe hypoperfusion, but they're asymptomatic. So in these cases, you don't do a bypass as long as they haven't had a stroke.
Okay, I would, of course, it doesn't completely match the guideline, but the progressive and hemodynamic compromise, I think we can recommend surgery if the patient accepts that.
Yeah.
And also another thing is asymptomatic choroidal channel development. Choroidal channel is again for the bad indicator for the future hemorrhage. So even though there are only a microbleeds from the choroidal channel, we may explain the patient the condition. And if the patient accepts, maybe we can move forward to the surgery.
Miki, that was a great run through. Just a couple things that come up as we hear it. Are you routinely measuring RNF-213 now and using that to guide surgical, which surgery you do and surgical treatment?
Thank you. If we can do that, I want to do that. I do all RNF-213 evaluation for all the patients, if the patient approved, but it takes a little bit, 1 month, 2 months. So not all the patients had the result before surgery. But nowadays, some of my colleagues in Kyoto and another city found a new procedure to make a rapid evaluation of RNF-213 for the stroke management. So in the future, maybe we can very easily evaluate the RNF-213 for all the patients before surgery.
And another phenomena that I've seen it in the past, and I do a little more EDAS, but talking to Gary Steinberg and the group in Chicago, that even if they're bypass, it's great when they do it and at 1 week, but by 1 year, about 20% of the bypasses are kind of reducing in flow or piddling out. Do you do angios at a year to evaluate that, or have you seen that same phenomena? Because I'm trying to figure out who to bypass, who to do EDAS, who's going to do best with either, with revascularization.
Okay, thank you for the great question. So this is a very important topic. Also in my series, some patients make a tremendous development of the pyrrhus and subsequently the reduced STA signal after the max development of pyrrhus. So it can happen, but most of the patients have the STA-MCA dominant pattern in my case. I don't know it's a genetic difference of them. But I think so it can happen in a rare occasion. STA decreased and only the pyrosynergiosis feed the brain. But I don't think it's a bad sign. It's a favorable result of the pyrosynergiosis development, I believe.
And then one quick, very special case scenario that I've seen about a handful of times now is younger individuals in their 20s and 30s show up with a hemorrhage, and their angio shows massive collateralization from the extracranial to the intracranial circuit on their own. You know, they have bad disease. It's already collateralized, but they've had a hemorrhage. What do you do with those patients?
They're very difficult. I didn't experience the very similar cases. So, which means that already a lot of pyrosynergiosis, not the intracerebral moya-moya, but which was a breeding source, brain surface.
Well, they have a parenchymal hematoma, and they have bad moya-moya, that is, they're a high grade, and yet they've already developed. They didn't know they had moya-moya before their hemorrhage, and then they've already developed collateral. I've seen about 3 or 4 of these patients, younger individuals, and I've just milked them through their hemorrhage and been following them, to be honest.
I don't have experience of this kind of patient.
Dr. Fujimura, thanks very much for this great talk. And can you quickly talk about the timing of surgical intervention after a TIA or stroke in ischemic moya-moya disease?
Okay, after the minor stroke, I wait 1 month. And in the patient with TIA, I don't operate when the patient suffers the crescendo TIA. Conceptually manage, and if the TIA decrease, maybe I make surgery. And for hemorrhage, I wait at least 1 month, because this is the inclusion criteria of JAM trial. After 1 month after the hemorrhage.
Thank you.
Hi, Dr. Fujimura. My name is Alfred. I'm from Boston Children's Hospital. I was actually curious, in your pediatric cases, your recommendation from the Japanese Society is either indirect or combined or direct. Have you found that the indirects are as effective for protecting hemorrhage or protecting from hemorrhage in the long run in the kids? I know that it's been studied in adults, but...
Thank you, the great question. I personally perform combined bypass for all the pediatric patients. It's my opinion, because of not only for the future, I think it's better for the future prevention of this hemorrhagic event. So, but now, the Japanese Society is also interested in this topic, and we make a multi-center retrospective study of the hemorrhagic conversion of the pediatric moya-moya disease patient after the 20 or 30 years after the operation. So now this is a very hot topic.
Yeah, I wonder if I could reach out and either collaborate or learn from your data set as well, since we have Dr. Scott's volume here, and I'm working on reporting on the indirect bypass 20-year outcome. But
yeah, and maybe OA-PCA bypass can play an important role for the rescue surgery.
Alfred, I can send you the contact info of Professor Fujimura, and you can reach out.
Okay.
Any other questions? Well, I hope we're going to see each other in person very soon. And maybe next time in Boston, and you can sit down with the residents and the fellows, and we can discuss some cases in person, hopefully next year.
It's my pleasure. Well, thank you so much.
Thank you. Thanks,
thank
everyone.
Thank you.
Thanks, Miki.
Thank you.